pediatric case presentation. I was at a urgent care center, prompt care in Adams Morgan, and we saw a variety of patients of different ages. I'm focusing on a case we saw of a 13-year-old girl. She had come in with fever, chills, and nausea for the past 3 days. We got a little more history. She was a 13-year-old African-American female presenting with the nausea, fever, also body aches and chills for 3 days. The mom had reported that she'd had a fever for 2 days. This morning it had been 101.5, but last night it had been as high as 102. She also had accompanying chills with these high fevers. She had also reported that she had generalized body aches, no focal pain, but just kind of muscle aches throughout. She didn't have any joint pain, any weakness, numbness, tingling, anything like that. She also has had intermittent nausea for the past 2 days, no vomiting, but she did have 2 episodes of diarrhea, no blood in the stool, but loose stools over the last day. She had also reported decreased appetite, but no abdominal cramping, no abdominal pain, and was tolerating fluids well. No respiratory symptoms, no coughing, sneezing, shortness of breath, or wheezing. Mild sore throat, but no ear pain or other ENT complaints. So she gave a pretty good history, but we had asked some additional questions that seemed relevant at the time. So we wanted to know if she had possible food poisoning. So we were asking about any new food she'd tried or anything that seemed old, molded, or potentially contaminated. We also were asking about sick contacts, anyone in the family or close to her, and then any recent travel. So she had, in terms of past medical history, had previously, about 4 years in the past, had similar symptoms and been diagnosed with the flu and received Tamiflu. She had also had history of several URIs in the past, none very recent, and strep throat when she was younger. Aside from that, she was a healthy young girl, no major medical history, no ER visits, no hospitalizations, no allergies, up to date on all immunizations. And she was aware of hadn't had any foods that were expired or questionable, no new foods, no one in the family with any similar symptoms, no sick contacts with flu, mono, anything like that. She had, however, traveled about a week and a half ago to Ghana visiting some family, had been there about 10 days over her spring break. So we wanted to get a little more detail about her travel history. She had been traveling with her parents and brother, been in Ghana for about 10 days. She had received anti-malarial prophylaxis prior to travel, starting about 2 days before. She had gotten Malarone and had continued taking that up to about a week following her return, so she had just stopped taking it a few days prior when she saw us. She said that she did take all of the doses, but that she had vomited up a couple of those doses. Her mom had encouraged her to take it with food, but I guess she had forgotten to do that a couple of times and had become nauseated after taking the pills. She also had reported that she was using bug spray to try and avoid bug bites when she was out and about in areas with more plant life and vegetation, and was pretty good and pretty compliant with that. But she had unfortunately gotten a few bug bites, some itchy bug bites that she thought might have been mosquito bites throughout her stay. On physical exam, vitals were pretty normal, but her heart rate was elevated. It was 108. She also had an elevated temp of 101.8. She did appear to be in some mild discomfort, seemed a little tired and just not feeling great. When she came in with the ENT exam, everything was normal with the exception of tonsils, which were slightly erythematous, but no exudate on them, and no other abnormalities. Ears looked good. She was fine CV-wise, S1, S2, no issues. Respiratory-wise was clear throughout. Abdomen was soft, non-tender. positive bowel sounds. She didn't have any splenomegaly or hepatomegaly, normal exam, no CVA tenderness. Skin did appear slightly pale, but otherwise was warm, intact, no rash, no evidence of the bug bites she had reported prior. And then my preceptor did a tourniquet test that I hadn't been familiar with previously. So the application of a blood pressure cuff or any sort of tourniquet or anything that's constricting to the arm, if you're looking for dengue fever, the low platelets can cause a petechial rash if you leave that cuff on. So we were looking for any kind of petechial rash, but didn't see it at the site where she had her BP taken. So this is just an example of a positive tourniquet test. So the arm on the left, you'll see the petechiae at the site where the cuff had been applied, but we did not see this with the girl. So diagnostic testing-wise, we wanted to rule out some more common things she might have picked up back home since her travel. Her symptoms did seem possible for mono with her fatigue and just generalized flu-like symptoms. So we did a mono spot, though that was negative. We also then wanted to rule out strep pharyngitis with her having the mild sore throat as well as the fever. That was also negative. And then since she did have these generalized flu-like symptoms, we wanted to rule out flu, but the rapid flu was also negative. So for differentials, like we had spoken about, the influenza was a possibility because she presented with the flu-like symptoms, but she did not have any respiratory symptoms, and the rapid flu was negative, so we ruled that out. We also were considering mono. She didn't have any contacts with anyone with mono, and the mono spot was negative, so that seemed an unlikely diagnosis. We also ruled out the strep pharyngitis. Her sore throat, though present, was pretty mild. She did have a little mild erythema of the tonsils, but no exudates, and the rapid strep was negative. So then we were considering possible illnesses that she could have contracted from her travel to Ghana. So malaria was something we were considering. She had received the malaria prophylaxis, but with the vomiting may not have gotten the full dose. And even with the prophylaxis, it was possible that she would have contracted that. We also were considering chikungunya, which could be presenting with very similar symptoms, though normally there would be severe joint pain with that, which though she had the myalgia, she did not have any joint pain. We also considered dengue fever. We had done the tourniquet test, but that wouldn't be diagnostic necessarily, so that was something to consider. But usually the symptoms would present within a few days of the exposure to the mosquito. So her presentation a couple of weeks after seemed more likely to be malaria. Also with dengue, there's often headache or retroorbital pain, and she did not have these symptoms. So based on all of the information we've gotten from the history and the physical exam, it seemed most likely that she had malaria. The symptoms and their appearance were pretty appropriate for malaria. It normally would appear about 2 weeks or more after exposure, and this was kind of a longer time frame since she had come back from Ghana about a week and a half ago and may have been exposed prior. She also had no joint pain, though she did have the myalgia, which would be make it more likely that it was malaria instead of something like dengue fever. And she had the fever chills, tachycardia, myalgia, fatigue, all of these things that could be associated with malaria. And although she had received the malarial prophylaxis, that wouldn't 100% guarantee that she wouldn't get the infection, as well as her potentially missing some of the doses, the key doses early on, with vomiting up potentially some of the pills. So our plan when we were considering that she may have malaria was to send her to the ER for further evaluation. Given the fever, the tachycardia, the history of recent travel to an area where malaria was endemic, our suspicion was pretty high, and we didn't have the capabilities to test her, but we wanted her to immediately be tested and diagnosed if she had been exposed to malaria. So sending her to the ER was warranted. She agreed to go with Mom. And then we were anticipating she would receive microscopic analysis of a blood smear to identify the malarial parasites, to begin treatment with either PO or potentially IV antimalarials, and some IV fluids if needed for tachycardia or if she were to develop hypotension with the malaria. And then if she was negative for the malaria, they would be able to do a workup for other possibilities to figure out what was causing these high fevers. So looking back on what we had done, it was very educational for me. My preceptor was much more knowledgeable about these tropical diseases than I was, but I realized that we hadn't perhaps provided enough education to the patient and mom on when you're taking the malarial prophylaxis, what to do if, since they can be very nauseating, if you do vomit up one of the pills. If it's within an hour of taking it, you should really take another dose to ensure that you're getting appropriate prophylaxis. So we were kind of trying to get the patient sent off to the ER and make sure that they were doing well, and we probably didn't spend enough time educating on that. I also had done a little research on the tourniquet test, which I wasn't familiar with, and my preceptor had talked about. And I was realizing that we hadn't done it appropriately. We hadn't left the cuff on for a full 5 minutes, which the World Health Organization recommends to clinicians if performing the test. You inflate the blood pressure cuff halfway between the systolic and diastolic pressures, leave on for 5 minutes, and then you allow 2 minutes to see that petechial rash appear. And so we hadn't really done that for an appropriate length of time, so we may have gotten a false negative on that test. So that was interesting to know the appropriate way to perform that. And then a positive test would be at least 10 petechiae per square inch on the skin at the blood pressure cuff site. I also hadn't really considered malaria and dengue fever as possible diagnoses for patients coming in, since they're not endemic to our area. But in DC, we do see a lot of international patients. We see a lot of patients who travel, who move to the area from abroad. So just being aware of the signs and symptoms of these common diseases elsewhere in the world is really important. So I had done a little research and found some really good CDC websites. I especially liked, there was one on dengue fever that offered case studies and some training for clinicians. So I have the links just posted below there. If you want to take a look at those, it was some pretty helpful information. And then my references are here.